Yes, hello and welcome to the Tulip Airway channel. This is video 7. This video concentrates on how to use a Tulip Airway, the basis and the foundation of its function, how to size it, how to inflate the cuff, the theory behind the 40 millimeters of mercury, 50 centimeters of water inflation pressure, and how to pick the right tube size. Right, so just to summarize this video, we're going to do a quick review, location, principle and function. I think each video needs to make sense to anybody who's watching it for the first time. We're going to basically look at the demonstration video 1 and 2 once again, but what we're going to do is look at different details. Basically, we're going to go through sizes, which there are 5. We'll also go through cuff inflation and cuff pressures. Again, I'll reiterate, 40 millimeters of mercury, 50 centimeters of water is a recommended tulip inflation pressure. You can, a little bit above and below is fine. We'll go through that. Then we will go through the tube sizes, and then we will basically talk about securing the tulip, the versions with a headband and those without, and just basically other advantageous points to know. Now, those are the tulips, as you can see on the left, no headbands, on the right with headbands and a lip guard. Now, that lip guard's important because you don't want that pressing onto the lips. It's supposed to guard the lips, not hurt them. There's versions with the headbands, which basically to my mind are the more optimal. Every airway needs to be secured, and so why not give you what you need. So basically the difference is the tulips is hands-free, it's directly connectable, and it's low stimulation. Will replace a Guedel quite successfully, but it will also replace iGels and LMAs for starved elective anaesthesia without any problem whatsoever. Now, the tulip works on a circumferential oropharyngeal seal because it's an oropharyngeal airway. It's not supraglottic. Now, I'm going to raise the issue of how lightweight the tulip is, and as you can see on this picture, the tulip is much more akin to a Guedel in size. It's slightly longer. As you can see, it goes into the oropharynx more here, but it's nowhere nearly as heavy or as large as the supraglottics. For example, this iGel weighs 5 times what that tulip does. So basically, tulip's good for eco, waste, plastic reduction, but you do need a catheter mount, swivel mount ideally, so you don't yank the tulip out of a patient's mouth. It must be secured. The tulip only weighs 50 grams, right? That means it can be pulled out if you're rough with it or you're hanging the anesthetic circuit off it. So avoid traction from the anesthetic circuit to avoid displacement and secure it properly. Now, basically the main point is please don't hang an anesthetic circuit off a tulip unless it's secured in place. It's tiny. If it falls out, it's the user's fault. Okay, it's an inanimate object. Right, going through the basic anatomy once again. This is where the tulip sits, where the nose and mouth become the oropharynx before dividing into the trachea and esophagus. So right there. That means the tulip cuff sits there, which means the tulip sits there. Now, just one more time, the tulip sits between the tip of the soft palate and the tip of the epiglottis, filling the oropharynx. The tulip seals in a circumferential manner, so it's occluding one tube with a balloon and sealing it in its entirety. That means it sits in the glossopharyngeal nerve, which means semi-conscious use. No, it induces swallowing, not gagging, not coughing, not vomiting. So semi-conscious use is possible, like a Guedel, unlike an LMA or an iGel. Now, let's go through demonstration videos. Now, what I want you to do is basically, it's not only good to recap how to use one, but in basically demo video 1, it'll just go through it. In demo video 2, notice the way the tube flexes straight. Put it in, straighten the tube, push it straight in. Now, the other thing I want you to do on video number 2 is to watch how the green lip guard is just proud of the mouth. It shouldn't be pressing on the lips. It shouldn't be that far out either. Basically, it's your guide as to how big your tube should be. The lip protector should do just that. It should basically surround the lips just proud. It's basically designed to hold the straps of the headband on, not squash into your lips, if you get my drift. Okay, this is the first tulip training video. What I want you to do is not just monitor how the device is actually put in, e.g. flex the tube straight. That flexibility is there to assist you to insert it, because a right angle bend isn't so easy to put in, which is why some people find difficulty in putting in Goodell's. So the tulip tube is designed to straighten. Now the point is that means that the tube itself is slightly softer. It's still very difficult to bite through, but this is a bite block. This is impossible. You cannot bite through this. Now the reason I'm pointing replaying this video is because you will see that the bite block is between the teeth of the mannequin. This part is just standing proud of the teeth, and this is outside of the mouth. So this is kind of the right sort of size to use. In the following video, because it's got wings, the next one is slightly too close to the lips. It might cause some damage, but just have a watch this one, and then basically when I turn the sound up, you can watch this. But just keep an eye on the size of the tulip, where it's sitting. Okay, this is the second video. Please just keep an eye on how the tube is flexed straight on introduction. That's deliberate, so it's easy for you to put it in. Right angle bends aren't so easy to put in, so a bit of flexibility in the tube straightens it out so it goes straight in. The other thing I want you to pay particular attention to is the location of the connector and the wings of the tulip. Well, I should call them leaves if it's called a tulip, but anyway. Basically, the leaves of the tulip that hold the straps. Basically, this hasn't got a head strap just because I'm using it for the demonstration video, but just keep an eye and see where this head strap, where the connector of the tulip actually is. This lip guard, which basically is masquerading as as the wings or whatever you want to call it. That's fractionally too small and slightly too close to the lips, but it works and it's functional. Just avoid damage is the primary point. Okay, one of the primary advantages of the tulip is how easy it is to use and how quickly you can learn to use it. Now, we're discussing this just because you've seen a mannequin video. Once you've used it in a mannequin, you should really be able to transfer it to the clinical environment quite quickly. That's quite unlike things like laryngeal masks, where the studies have shown that you can't very easily transfer mannequin skills or mannequin training to the clinical situation. But in a tulip you can. After the clinical trials that we did with 100% success rates were after a single demonstration. And so that, as I said before, that seems to have been addressed. Single mannequin teaching does transfer into genuine clinical ability in real humans, as the clinical studies we did proved. Now, let's go through the 5 sizes. Okay, there they are. All right, headband, no headband. Basically, in terms of size, in terms of small to large, 0, pediatrics 5 to 10 years of age. Yellow, pediatrics 10 to 15 years of age. Green, adult female. Orange, adult male. Red, extra large. Now, going through this again, blue, yellow, green, orange, red. Now, you clever people will notice this thing. That's a 6th, but that is a clear connector tulip for endoscopy, bronchoscopy, and endotracheal intubation. So, blue, small child. Yellow, large child. Green, adult female. Orange, adult male. Red, large adult. That is the same color coding in the United Kingdom, except for these two. I made those up. Now, weights are quite useful, but again, the biggest indicator is how much of the connector is sticking out of the mouth. In terms of volume, the smallest has 30, 40, 50, 60, etc. All infiltration pressures are 40 millimeters of mercury. This is important because this is mucosal perfusion pressure. In other words, the pink stuff in the side of your mouth has blood flow. If you press too hard, you basically bleach it. You will stop the blood flow. If it's in there for too long, you can get necrosis, damage, perforation even. With a tulip, because it's located behind the tongue, you want to avoid obstructing the tongue's blood flow. So if you get a blue tongue, you've probably got a too tight a tulip. Right, so mucosal perfusion pressure is 40 millimeters of mercury, 50 centimeters of water. The tulip has the softest cuff of any anesthetic airway that we've tested. Laryngeal masks tend to run over 120. They can run less, of course, but they don't tend to. Okay, so let's go through the airway sizes. Let's talk about inflation volumes and volume printing. Every single tulip has printing on it, right? 40 mils, 50, 60, 60. Size 1, 2, 3, 4. Now, if you look on here, pressure, 50 centimetre, under 50 centimetres of pressure. Now, you can run 40 to 60 and there's no problem. You just got to know what you're doing and keep an eye on it. You know what I mean? It's not going to cause you any harm as such. Now, this is an early watercolour of mine, but you can see, right, there's the laryngeal inlet, or my version of one. There's your esophagus going down there, right? So there's your, and this is your oropharynx right up here. Now, this is your palatopharyngeal folds and the whole of the back of your mouth. These are the palatopharyngeal folds. Those are your tonsils, right? Nose, mouth, tongue, teeth, lips. So the tube goes through, over your tongue, through the hole in the back of your mouth. Your uvula would be there. This is your palatopharyngeal folds. There's your tonsils. That's still connected. The cutaway then goes behind it, and you can see that what the tulip does is control the tongue. Tip of the epiglottis just denting the front of the cuff of the tulip. Can you see that? And then the back of this tulip slopes behind, makes the most of the oropharynx and the glossopharyngeal nerve, and so it ventilates straight into the inlet. But that's also how you can do bronchoscopy, endotracheal intubation, and upper GI endoscopy. From here you can also see, if we take these tonsils out, this round tube, you can fit a Boyles-Davis gag, but if you take these tonsils out, this is fully occluded below and behind. Okay, now that's another early watercolour. You've seen this one before. Tip of epiglottis, tip of soft palate. Let's go to the next one. Now, this is clearly an anterior view. There's the hole at the back of your mouth. It should be filled with tulip cuff, not in the mouth, but behind those folds. Tonsil, palatopharyngeal folds. There they are, palatopharyngeal folds, uvula, tonsils, tongue, right? That black hole is now full of tulip cuff. Right, here's a cutaway, so the top of your head's gone. That's your tip of your epiglottis. You're looking vertically down, right? So here is basically your tongue. There's your tonsils. There's the bottom part of the palatopharyngeal fold arch. That's the tip of your epiglottis there, right? That's how a tulip goes in your mouth, round a corner, completely fills your oropharynx with cuff. I think that's quite good. Anyway, so this is like from looking from behind you, looking forwards. All right, so your eyes, the eyes are here, and they're looking into the paper. That's the back. They're looking from your. This is your nasal space with your turbinates, but you're looking from behind, and the patient is looking eyes here, into the paper. So what's happening here? There's your laryngeal inlet, right? Now that's where a laryngeal mask will fit, right around there, okay? So here's your palatopharyngeal folds, there's your uvula, there's your tonsil, there's your tongue. Now, next, that's where a tulip sits, bang, right? So it completely occludes the area, just covers, and remember there's a bit of a the back end, the surface that's closest to us is slightly longer, isn't it? So it slightly comes over the tip of the epiglottis at the posterior aspect, right? But you can see it completely circumferentially seals. That's the point. So, principles of fitment. Basically, you inflate to fit. And now, every cuff can be expanded to fit, a size above or below. The only limiting thing is how much of the tube's in and out. If it's too far in, that's bad. If it's too much out, that's less bad, but it's still not perfect because the tube's too big. But the point is, that's okay. Now, the tulip has the softest cuff of any airway device. We've measured them all, and tulip, easily runs the lowest. You can run a tulip with, 30 millimeters of mercury. The only problem with underinflating a tulip when you're getting ambitious with let's run super low pressures, is that if the cuff is not fully inflated, it doesn't displace the tongue and the anatomy, so you can increase chances of your own obstruction because there's stuff hanging around. So if you inflate it fully, it will open the space. But the point is, all you've got to do is open it fully. You don't have to push the pressures sky high. It doesn't have to be a sphere of tenseness, It's basically you just get the shape and then reduce the pressures. Now, that's roughly about 40 millimeters of mercury. The cuff should be full. It should displace everything without being traumatic and hard. That complements the largest breathing tube of any airway device. Okay, that's on purpose. That was for the endoscopes, the bronchoscopes, and the size 7 cuffed ET tubes. The connector was remade just for that. Okay, let's talk about leak. if you get a leak, which quite often you just don't usually, all you have to do is inflate a bit more, open the cuff, and it will just obliterate the leak. That will happen every time, unless you've got some crazily like small size in somebody huge, at which point now the connector is probably in the mouth. So if it leaks, just inflate more. It probably will not matter, right? The only time it will matter is if it's ENT. Why? Because if you've got air coming out, now air coming out will be pressuring upwards, so you could argue that it's pushing blood out, right? But not happy. Get it right. So what you need to do is basically just make sure you've got no leak, then you can depend upon blood tight as well as airtight, can't you? Now, when I say it won't matter, that's not just be cheeky for the hell of it. You'll probably have more than 20 centimeters of ventilation pressure anyway. All right, so it'll probably only leak if you're overdoing it. The leak then limits IPP ventilating pressure, so you can consider it a good thing. You will have control. It'll just might make a noise. To be honest with you, I don't think I've ever heard one. Now that then means, because it's a tube with the cuff opening up around the tube, you can inflate to fit. So that means a green can fit now, one size above and below usually, so long as the tube's not too far out. Just watch the tube size, okay? Okay, let's go to tube size. Here's what not to do. This is a size 3 orange, which is designed for adult males, and it's far too big for this woman, right? And how can you tell? Look at the amount of space that's there. This is supposed to be in and around here, right? Not touching, just proud. That's massive. So this is completely too big, right? So the lip guard should just be proud of the mouth. Again, that's too big. And that's too small. Right? Now that's digging into her lips, isn't it? That's not great. That's going to be good, not great there. But listen, people who gave me these pictures, no criticism is ever intended. What this is, these people are learning. This is a new thing, and this is what the video is about, to basically assist. Okay, let's talk about securing the airway with a headband or not. Now, basically, to my mind, you all need a headband, so why don't you just buy a Tulip with a headband? I mean, you're going to do it anyway. Now, the point is, this version, which is cheap and cheerful and for hospitals and all that, basically that will need a head tie or sticky tape. It will, right? Otherwise, you're going to pull the Tulip out with the weight of the anaesthetic circuit. Now, other tips. Leave the Tulip airway cuff fully inflated. All right? Let the patient extubate themselves when they're fully awake. This is one of the top benefits of Tulip, so just leave it. Turn the anaesthetic off, turn the oxygen up, leave them. All right. What does the fully inflated cuff do? It wipes the mouth secretions of blood. Now I can't promise you it's clean, so I recommend that you still suction. That's a fact, but it will help, right? The other thing is the tube, the breathing tube of the Tulip, which is flexible, mind, so it will straighten on removal. Basically, the patient can still breathe because they've got a cuff with a tube through it. So as it pulls out, the cuff is still holding the tube central in the mouth, so you can breathe at any stage of extubation, which is not like an LMA or an iGel, which obstructs. Right. So the next video is all about costs and how Tulip saves money, right? So that'll be video number 8, and I'll see you there.